in NIPT, multiple pregnancies, and inconclusive results. Prof. Julani, please.
Thank you, Madam Chairperson. So, I was smiling when I was sent this talk to you. Decided to challenge me, but that's okay. I'll try my best. These are my affiliations and declarations. The ones in yellow are basically to highlight my role at the university and my role in field medicine societies, and also to mention that I'm a founder of a company called INEX in a way. So NIPT is the most accurate screening test for common autosomal trisomies of aneuploidies, trisomy 21, 18, and 13, and in unselected populations. And it's basically known to identify those with high probability. So you can see this from the ISPD statement, 21, 18, and 13, what the sensitivity, specificity, and PPVs are. This paper was put together by Now, in this paper was a very nice chart that talks about the counting method of MPS, massive parallel sequencing. And what it does is genome-wide NIPT, it's up imbalances in chromosomes, it's up maternal chromosome imbalances, and then profiles. The second version is one that uses a microarray, and this is a familiar technology. Unfortunately, it does not pick up aberrations of off-target lesions. And it uses statistical method with a priori information to try to understand what's going on. And the third is slip-based assay that would look at maternal white blood cells and look at the sequences from there and compare them with what else they're seeing from the placenta. They do not generally use, when they started, they used the paternal sequences, now they don't. It is able to detect triploidy and zygosity in twin pregnancies. Let's start first with multiple pregnancies, because the common misconception that's being posed on a regular basis is you need zygosity for multiple pregnancies, and you need that to work it out. I want to have a look at that. So if we take a monozygotic twinning, right? If it splits a bit further, if it splits after 13 days, we get a conjoined twin. If it splits somewhere in between, you get MCDA, MCAMA twins. And this audience is very familiar with this. If it splits very early, then you end up getting a dichorionic twin. And the placenta can be fused, or the placenta can be separate. So keeping this in mind, let's have a look and see here. If you take twinning, so dizygotic twins, or DCDA, are 100% DCDA. There will be exceptions to the rule. There are always exceptions to the rule, okay? These are rare examples, but we're talking about the more than 99% of the cases, or 99.7% of the cases. So dizygotic twins will always be DCDA. Now, if you take a DCDA twin, 80% will be dizygotic and 20% will be monozygotic. And of course, we know about the lambda sign. We know early on you may see the thick chorion surrounding the tissues, and then lambda sign. You see 2% later on, this chorion gender later on. Now, if you take a monozygotic twin, you can of course get your MCMA, MC conjoined, non-conjoined, MCDA. All monochorionic twins are monozygotic. And if you come to DCDA, DCDA is what it is. Now, therefore, all dizygotic twins are DCDA, all monochorionic twins are all monochorionic are monozygotic, it's a tongue twister. Most dichorionic twins are dizygotic, and some dichorionic twins are monozygotic. You're going to get this around your head, and I know it's difficult. It's difficult for all of us. So let's try to package it in a different way. Let's take all twins to begin with. The twins can either be dizygotic or monozygotic. 70% of the twinning will be dizygotic, 30% of twinning will be monozygotic. I throw a ballpark figure to you, 2/3, 1/3, right? Now we break it up. Now the dizygotics will be dichorionic. The dizygotics will be dichorionic. The monozygotics will either be monochorionic or dichorionic, a 2/3 to 1/3 ratio. Now let's put the dichorionic all together. Makes it a bit easier now. Now we go back and say, if you want to take a picture, take this picture, because this is the easy one to remember. Now we go back and take the dichorionics together, and 20% or so will be here that got monozygotic, and 80% will be here that got dizygotic. So now it's easier to understand. Okay? This is the fundamental to what I'm going to say next. Now you actually understand that all dizygotic are DCTA, all monochorionic are monozygotic, most dichorionic are dizygotic, some dichorionic. It's a bit easier this time around. And what you want to remember is about 20% of DCs are going to be monozygotic. Okay? How do you recognize the DCs? How do you recognize the DCTAs and the chorionicity? Well, Steve Carroll and Pippa Carl already showed this a long time ago, that the accuracy of our ultrasound is extremely good. Right? Look at the p-value they showed. Pay attention to p-value. You won't get this p-value with cell-free RNA or cell-free DNA. You won't get it. It's phenomenal. Alright? So look at the sensitivity, look at the specificity, look at the PPVs, look at the NPVs. And we've been teaching about PPVs over and over, just look at the PPVs. So please understand, something that I teach in the university kids on a regular basis, you need to look for orthogonal information, three-dimensional information. So the stuff you get from the plasma is only one dimension. Ultrasound is a different dimension. They are in opposite direction. You add the information together, it's very powerful. Okay? So think of orthogonal information. Don't look for correlated information. And you've done this again and again in what we've done when we first tried to bring first trimester screen or Oscar into the country. And therefore look at the accuracy. So chorionicity. Or we understand chorionicity. But is zygosity or chorionicity more important? The data is very clear. Look at this. The fetal outcomes in pregnancy is related to chorionicity rather than zygosity. Okay, if you look at this, this is a monozygotic monochorionic pair compared to dichorionic and dizygotic. Fundamental difference is chorionicity over zygosity. And you get it from the ultrasound. And therefore you need different information to come together and use it to help you make your planning and diagnosis. So, NIPT is the most accurate screening test for common autosomal aneuploidies, T21, T18, and T13 in whatever population. Okay? It is, and zygosity is not an indication for NIPT or NIPS. You don't do this test to look for zygosity. Doesn't matter what I tell you. Okay? So then you go and say, okay, let's have a look. What do we know? What do we know about NIPT, twinning, and SNPs? Okay. So if you do the search, you'll find 6 results. Of the 6 results, you'll find 5 out of the 6 are published by commercial interest. Alright? So if you look at this information, rather than any other information, then that's what you get. Don't take my word for it. It's all over the publications. Everyone tells you what they're all commercial interest. Right? So you need to understand what this technology is all about. So let's look at the technology. Okay, now if we look at take a chromosome 21, T21, and we say it's maternal origin most of the time. I'm sure you already know that. Most of the time in T21, it's the mother's chromosome extra that comes over, so it's a maternal origin. Right? Now have a look here. Let's do a SNP-based assay first. So you start with this, and you have let's give it an advantage. Let's give it a 20% fetal fraction, not even a 10%, or 5%, or 3.5%. Let's give it a 20% fetal fraction. That's 90% this particular allele. Now the interesting thing about the way SNPs work is they split them apart. So you get an AA version, a BB version, and an AB version, or BA version. Okay. So this is what it looks like. This is how SNPs work. And this is the maternal SNP. And now when you look for the fetal SNPs, they get a bit more noisy because you have more versions in there. Okay? And you're going to try to tease this information out from the background. So remember, we've just increased noise. Pay attention, we just increased noise. when we've gone across here, we've created more noise, and so the signal to noise ratio has gone down. So therefore, we need more fetal fraction. And you've probably heard in the course of today, many speakers told you, fetal fraction is the key, and you're not getting good results, because of fetal fraction. And if you use this technology, you just need more fetal fraction to understand it. Straightforward, right? By comparison, let's look at the other technology. The other technology is quite simple. You know the extra chromosome is coming from the mother. You don't get those SNPs. Is there overrepresentation of 21 or not? And you say yes or no, finish. Right? So just count. Just count. Okay? Let's have a look. If you're going to count, let's look at singleton, for example, and take 21 versus, you need a reference chromosome, you need some background to compare against. So let's take chromosome 3 as an example. And then you count the chromosome 21. Now it's euploid singleton, it matches. All good. So you know 1-to-1 ratio, it's fine. Now if it's going to be a little additional information, and remember, you may have 5% more DNA, 10% more DNA, 15% more DNA, one extra chromosome, just a little bit more information. So you get an overrepresentation of chromosome 21. You think, hang on a minute, this could be Down syndrome or trisomy 21. What happens if you now want to change the technology and use it for multiples? Same method. Because the chromosome extra is coming from the mother, right? Same method. Just bring that. Just count. Now what happens if you want to now move this to twins? Right? What about you take this method and move to twins? Okay, let's have a look. Now monozygotic twinning is going to be the same genotype of the mom and of the two twins, right? So you get one signal, you get the other signal, and then you get the ones in between. And here you get a slight additional variation, but not too bad. Quite easy to make a call. You go to dizygotic, the noise decreases, of course, because you got two different additional babies in there telling you things about themselves. They're screaming out things about themselves. You just increase the noise. Now you're going to make a call from this additional noise. Right? So, with this one, not too bad. With this one, far more information to tease out. Okay? So let's have a look at what this actually looks like. If you take an MCDA twin, you may have one signal, another signal, something in between. Right? You take MCDA 21, you get a bit of additional information here, still okay. DCDA normal, a lot more information has come in because now you've got 3 individuals in there you're looking at. DCDA abnormal, a lot more information because you've got additional signal, and then you've got a little additional signal to deal with. Okay? So the answer is just not. Okay. Now, yeah, so most students die for having, as you know, therefore that issue of the noise comes in because most of them die for having. Okay, so we keep in mind that at the end of the day, what we're looking for is the chorionicity, because we use the chorionicity to guide our care, and this technology, ultrasound, that we have been doing for a long time, is but still by far the best in terms of identifying chorionicity, and that's the one that will be far more important for us in managing our pregnancy. Okay, so will zygosity help us inform which fetus is affected? All right? It is absolutely correct. Okay, and that is the power of a SNP-based assay. So if you have a vanishing twin, and you earlier somebody asked a question, if you have a vanishing twin, there's two amounts of information coming in, one from the vanishing twin and one from the live twin. Okay, there's a flow of fetal fraction information coming in. Can a SNP-based assay tell you whether the vanishing twin is male? Yes, it can, because it can read it, it can see it. So that's a strength of the technology, right? What it cannot tell us is whether zygosity will actually go and tell us which fetus is affected. We still can't. So if you've got one with thick knuckle translucency and one with not normal knuckle translucency, maybe the one with thick NT is the one you need to pierce, or maybe you need to confirm both. Can it tell us which fetus T21, male or female? No, it can't. There's no evidence to that. No evidence that says it's the male one that is T21. And the reason is because, as Professor Koi just said, the DNA is all fragmented. It's not like cell-based NIPT or long-read sequencing. You can run, they'll read a lot more. This one's DNA is all fragmented. So it's so fragmented, we cannot recompose back the one that's coming from the male status and the T21 status and match it together. At least not yet. Maybe in the future we can. But right now we can't. So there's no evidence to say that it can tell us which fetus, the male or the female fetus in the diaphragmatic pair is T21. We can't do that. Is it more dependent on fetal fraction? Yes, most likely. I say most likely because we still don't have evidence to say that it is or isn't. But theoretically, you can see it should be because it needs more information to make that call. Will it be more accurate compared to, will either one or the other method be more accurate? So, will it be more accurate than the counting method? There's no evidence to say that. Does it detect chronicity? There's no evidence you can find chronicity. You can only find velocity. Chronicity, you still need your ultrasound. Okay? Now, this is the data coming from ASMA and from ARIS, and they looked at the twin pregnancies using a counting method, and this was published recently. And you can see their sensitivity and their specificity is very high. Why? Because just count. It's quite straightforward, right? And then you see this paper by Bu and Han, where they put all the other papers together and looking at prospective information, look at the counting methods. These are all counting methods. Look at the sensitivity and specificity. Not surprising. It's just counting. It's just extra information. T21. If you go to T18, prospective method, counting method. Look at the sensitivity and then look at the false positives. Very low. Okay. Because you need simplicity. So keep it simple. Right? Aim for the simplest technology. Don't let technology confuse us. Right? We control the technology doesn't control us. Right? Keep it simple. Use simple technologies. Now, what about inconclusive? So a long time ago, we brought the words inconclusive in. And of course, I'm regretting like crazy that this word came in and I was one of the people that wanted to use the word. We used the word inconclusive at that time because we wanted a basket where things we couldn't make clean, and for our clinicians, we wanted to put in this basket and say, don't act on this. The whole idea of this word was, please don't go and act on this. We don't have information, we don't know what to do about it. The ones we know, act on that. But now this has come back to bite us because now the inconclusive is really becoming conclusive. It's beginning to show information. It's beginning to give us data that we are in the future will be able to act upon. And I would encourage the societies around the world to start changing this language or teasing it out. Okay? Because this is causing more confusion than anything else. So leaving the term in place now, inconclusive, what are the common causes of inconclusive? We heard from TC, low fetal fraction is a problem, right? So one of the commonest reasons is low fetal fraction. The other are technical issues, and the third is maternal origins. So we take low fetal fraction, you might get insufficient fetal DNA or placental DNA, insufficient amount. And that could be. Time and again, people try their best. I don't know why they do it, but they want to make that call so early. They go and take maternal blood early, and they want to look for fetal DNA. I understand it works most of the time. Sometimes it doesn't work. There's just not enough fetal DNA in there, right? Or placental DNA in there. And of course, there are other reasons for that. It's influenced by maternal weight, by gestational age, and by multiples. Technical issues, lab errors do occur. Of course, they occur, just as all our other errors in life occur. Sample degradation can happen, especially if transport is a long time. And then maybe maternal origins, either blood transfusions or organ transplants, and uterine fibroids or malignancy. If we tease this out further, is insufficient fetal DNA, gestational age, placental mass, multiples, including the vanishing twin, which we heard about just now, and maternal BMI. If we look at technical issues, there can be lab errors, and no obvious biological or technical reason in two-thirds of the cases. This happens from time to time. We just don't know what's going on. And maternal origins. Now, what are the maternal origins? Maternal mosaicism, we heard about that. Benign copy number variant, loss of X-chromosome maternal buffers. So, this is an important one. As we get older, the moms, the women some of the X chromosomes will start to go away, right? And as men get older, some of the Y chromosomes go away. The sex chromosomes degrade over time as we get older. So if they do degrade, then you cannot be too surprised that you might get if you're looking at a fetal condition, you might get a sex chromosome antibody signal, and it could be a false positive. And often you get, and quite interestingly, and I explained this in previous lectures, the XXYs or XYYs are much easier to find, are lower false positive than the X naughts. And the X naughts are a higher, lower positive predictive value and higher false positive, mainly because of this phenomenon, right? So this happens, and then we tend to see X naught. The ratios are not right, but then often our moms are also older. So if you see that scenario, don't be surprised. You will not get your XOs will not be as accurate as your other X sex chromosome antibodies. Blood transfusion, organ transplants. Again and again, people forget about this. You know, so we've done. I've signed out or looked at least about close to 40,000 NIPTs. And sometimes the problem is people forget to tell us that this person had a transfusion or had a transplant, and there's so much noise in the system, and you don't know what to do about it. You heard just now from GC that 8.6% of all cases might have SCA results, uterine fibroids, maternal malignancies. So here you have vanishing twin. Now, a vanishing twin, we talked about it, and I did mention that the SNP-based method is able to distinguish the genome of the demised twin, and that's important, okay? And the counting method cannot, right? But these days, it's always still better if you have a vanishing twin not to rush in to try to make that genetic diagnosis. Use the ultrasound, use the OSCA, use the FTS, and use the NIPT if you want to as an adjunct or as an additional tool. Because you will get additional noise, and you don't want to make the wrong call for the patient. I talked about the X chromosome situation in aging moms, and of course, other inconclusive results will be mosaicism in the mom, and there can be transplant. Okay, I just want to end with two examples of rare causes. What we saw earlier were the common causes which I talked about. What about rare causes? What about fetal mosaicism and maternal occult malignancy? So I'll give you one case. This is was put in by Arundhati. So here you see a case of a 37-year-old individual, NIPT at 12 weeks, suggested high risk of trisomy 13, detection of Y chromosomes in the fetal bracket. At 16 weeks, they did a test, and what they found was a mosaic 13, and a 3 to 36 ratio mosaic 13, so 7.7%. So you will start to see things now that you've never seen before. Now that particular result showed up as a possible 13 trisomy. It could have showed up as inconclusive. So right now you must begin to realize that the inconclusive will start to unravel a lot of information to you. Because what's happening on the lab side of the story, you're just seeing a lot of noise. And you're trying to tease out the noise. And not every piece of noise can you actually call, right? So you will get the inconclusive will start to reveal something. In this case, it could be called as a 13, and even if it's a low-level true fetal mosaicism, it can still be seen. So if you can see a low-level fetal mosaicism at this level, can you imagine what other noise you can see? So in this country, as you know, we've had a couple of cases, unfortunately, of serious maternal conditions that have revealed over time, and so we've had to deal with those. And here you see this particular case. This is done with a BGI group, where they looked at 1.93 million pregnant women. This was, I don't remember which year it was. 2 million women undergoing NIPT. And of the 2 million undergoing NIPT, they found that they needed to interview about 500 odd with something called multiple chromosome abnormalities. So the whole genome is noisy. You know, I was lucky enough because I got to see some of the data that they had. The whole genome is noisy, quite fascinating, and you don't know where this noise is coming from. So then they interviewed the individuals, and they found 41 cancers. The rest were non-cancers. Right? They found 41 cancers. And if you do the MCA and you repeat the MCA again and again, if it keeps going away, then maybe it won't be. But anything other than completely going away, it could be a malignancy floating around. Now, I'm sharing this data with you, but we cannot act on it yet. We need to give our researchers, our investigators time. I think that we'll be in a position in about 2 or maybe 3.5 years, where we will have a proper algorithm on what to do with MCAs and the risk of maternal malignancies. Right now, we don't. We're in a position where we don't have that kind of information to be actionable. We only are in a situation where we can start to see things, right? And so what they did was they tried to identify which cancers they were, and you can see the number one was breast cancer, then was a lymphoma, liver, gastric, colorectal, and other smaller numbers. And you see many of them were either stage 3 or stage 4 cancers floating around in the mouth. And you see the signal. Okay, so that's what I wanted to share with you both the multiple pregnancies as well as the tricky situations and inconclusive. I just want you to understand that the word inconclusive is I hope if my dream comes true, this word inconclusive in 3 to 5 years will never exist anymore, because we'll be able to tease them down to their individual components and share the individual components. It's a noisy term that causes a lot of trouble to all of us. So just remember that NIPT is the most accurate screening test for common autosomal trisomies, and is not for other stuff, and in unselected populations. And this chart is quite helpful, and I know some of you took pictures just now, you can take this picture. This chart is quite helpful to understand the main technologies out there. With that, yeah, I would thank you.
Thank you, Professor Chulani. We do have some questions here. One question from our audience. Some fetal conditions can lead to low fetal fraction. At this point in time, is it worthy considering offering amnio after 2 inconclusive results?
Yeah, so when you see an inconclusive result, or if you are told it's an inconclusive result for whatever reason, any of the reasons, you already need to think about the need for invasive testing, because an inconclusive result alone already puts the individual at a 7-fold increased risk of fetal aneuploidy. 700%, 7-fold increased risk of fetal aneuploidy. So we say inconclusive result. The real question you need to ask yourself is, when like TC was saying, if you get an inconclusive, the real question you ask yourself is, do I need to repeat it? And in some cases you will need to repeat it, in some cases you do not need to repeat it. So if the thinking is this sample may have got degraded on the way to the lab, or the thinking is this is a technical issue, yeah, repeat it. But if the thinking is this could be a biological thing and we don't want to miss a biological scenario, just no need, because information is very different from when we first started. When we first started, every inconclusive needed to be repeated. But we are different now. So you can look at the data and look at that, try to understand whether this one needs to or does not need to. But if you do have 2 inconclusives, then I think personally I would ask the patient. I'm going to say amniocentesis, not invasive fetal testing, because the material is placental. CVS is not the ideal choice. Not that people don't do it, not that there's no place for it, but CVS is not the ideal choice because you're looking at the same information.
So what if the second draw has a conclusive result? Do you still get worried that there could be, would you still do an amniocentesis?
Yeah, so that's always the prisoner's dilemma, right? Because so when you make the second call, the second goal, you are putting yourself in that trajectory to that situation. So that's why making that decision is important thing these days, right? But if you do go ahead and do that and it's clear, it's fine. Take the second one and use the second results. Because almost all the time it will be accurate. Almost all the time it will be accurate. There will be errors, but almost all the time it's accurate.
So we have another question. Some fetal conditions can lead to, another one. For counting, in the event that there is a cross-contamination or index hopping, would there be an increased risk for false negative since most samples are normal, since one would not be able to tell if there are extra genomes?
I cannot answer that specifically because I don't understand the scenario being presented. But literally, if the extra genome present, you will get a noisy signal.